in time. See. Good afternoon, everybody. Thanks to all the organizing committee and for the invitation, Professor Susanna and Shengel for the great effort they did to organize this very fruitful ROP course. Of course, ROP is very, very important issue because it's my sympathy and pity to find a child from first day one he's blind. This is a pity for both the child and the parents. And I think nowadays we are all, even in my country, we are acquainted very much with the ROP, and we have screening programs for all incubators. Any hospital with incubator, we have screening programs that ophthalmologists go from now then to screen the children. And I think follow-up of the patients, as previously mentioned in the previous lecture, is very, very important. Even when we see nothing in the posterior pole, just follow-up every month is required for the first year of life, because it might happen to develop at any time. I will talk from the investigative point of view, the ultrasonography in ROP, that as we all know, retinopathy of prematurity is leukorrhea plus premature baby number one to be the ROP, till we differentiate. But it's a highly possibility of being to be an ROP. And when it's early diagnosed, early intervention is the best for this child, even according to the stages. And really, I got the point, and I was convinced that with the Shengel lecture that to do even surgery for stage 4 and 5 to save the eye, cosmetically the eye of the child, I think it's a good decision. Though, in my opinion, as an investigator, I was so for the prognosis of the surgery, but even though we'll gain for that intervention. For going to the stages of ROP clinically, it was covered. The incidence of ROP, when we know that 7.5 of the premature infants, 32 of them will be having different stages of ROP, and significantly it's increasing with the gestational age and low birth weight. And to know that 70% of low birth weight of 1,250 grams will develop ROP is really a serious issue. And this is one of the studies done in Egypt, in Upper Egypt, that they screened 216, 66 of them, 30% developed ROP of the 216 of premature babies. 27 were stage 1 and 6% stage 3 and above. The incidence is very high with the gestational age group, and with low birth weight, it's 100%. If they will go for incubator and high oxygen level, it will be 100%. How serious it is. And it, of course, increases with sepsis, anemia, blood transfusion, bronchopulmonary distresses, oxygen therapy. All these are very high risk for these premature deliveries. To prevent ROP, it's really an issue which is very difficult to give steroids to the ladies who are premature, used to have a premature delivery, to reduce complication of retinopathy of prematurity. Antenatal steroids to the mothers who are gestational before 25 weeks of gestation. This is an issue. It should be taken in consideration. But of course, the precautions and the screening of children is very, very important for ROP, not to be delivered or discharged from the incubator except with certified ophthalmologist examination for these babies and for follow-up. This, I think, the most important issue with retinopathy of prematurity. Going for ultrasonography as a part of the documentation of ROP, of course, it's very crucial diagnostic tool, as we all know the difficulty to examine a premature child, a baby, 1.5 kilo, very small, narrow pupil, not dilatable, very small palpebral aperture. It might be very difficult to dilate. So ultrasonography will go on to document the vitreoretinal interface and to plan for the surgery in cases of severe ROP and to put the staging of these babies. So ultrasound is really an indicator for retinal configuration, the type, the degree of retinal detachment. Ultrasound also will document if there is subretinal or choroidal hemorrhage, which is often present in advanced cases of ROP, and to evaluate, document, and the progression of the disease and follow up after surgery. Though, of course, the RAD-CAM is an excellent screening tool, but it might be not available on hand in all hospitals and especially in developing countries, and it is a bit more expensive than going for ultrasonography. But of course, RAD-CAM, especially if we need to do fluorescein angiography for those children, it will be of great advance to take the decision for laser therapy. In stage 1, we can document, of course, by ultrasonography, we'll find retinal thickening. Here, retinal thickening is documented in ultrasonography, and this might be correlated to the ridge it can be seen. And here is another case with the localized temporal macular detachment in the case, and the other eye of the same child with advanced ROP with total tractional retinal detachment. And this is another case with advanced ROP in which I love the terminology, previous terminology of retrolental fibroplasia, because really it's a retrolental. Sometimes even misdiagnosed that it's cataract because it's so anterior or retrolental that it's anterior vitreal severe PVR with total retinal detachment, thickening of the choroid, as we can see here. And the other eye with total tractional retinal detachment, but still there is an area with separation to the vitreous, and we can detect it and written in the report to facilitate for the surgeon to localize, as Schengen said, to see the area where they can enter with the trocar in vitrectomy, not to enter in exact retinal, to do a retinal break, complicated retinal break. And this is a case of a younger age group who presented with the regressed ROP, where the dragging of the optic nerve hand and the whole macular area with disorganization of the macular area, and here the pigmentation, secondary pigmentation, not to be misdiagnosed with retinitis pigmentosa or rod dystrophies. And this is another case of advanced ROP, a regressed ROP, and on the other eye of the same child with a total retinal detachment not interfered with clinically. Another study was done with early cases in Malaysia, and these are early cases where retinal thickening. We can see here a protrusion, a vitreoretinal protrusion, which is the ridge seen in the temporal area, and here another higher ridge with thickening and irregularity of the retinal surface, and to advanced retinal detachment, shallow or total tractional closed funnel retinal detachment in advanced cases. But don't forget to go for the differential diagnosis, because it might be a remnant of the posterior hyaloid canal, and this is just a protrusion, whether filamentary or triangular thickening at the optic nerve head, and it's localized in the optic nerve head. Usually it doesn't extend to the retina, as the case of retinopathy of prematurity, projecting in the vitreal cavity or extended by vitreal floaters anteriorly to the posterior capsule of the lens, or the other case of persistent hyperplastic primary vitreous, where the triangle is fixed, and it's opacification of the vitreous rather than a closed funnel retinal detachment, and it's a microphthalmic eye, usually unilateral, not bilateral, and there is no incubator history of incubation or low birth weight. And this is another case in which there is vitreoretinal changes, but here at that site there was thickening in the retina, and there was no incubation. There was no history of any incubator or prematurity. Was one eye, and we can see that it's normal sized because she was about 2 years old child, and this I said to be correlated to red cam and the clinical examination, and found to be a retinoblastoma. So not only the vitreoretinal proliferation, but also if you have thickening somewhere, it should be differentiated by all means, and correlated to a red cam is very beneficial. Microphthalmus or nanophthalmus also can be presenting in these cases, with here a case with persistent hyperplastic primary vitreous, and the same eye of the same child with the both eyes having choroidal coloboma. We can see the irregularity in the optic nerve head shadow with a retrobulbar cyst, and this is a leukocoria in an eye, but it's totally different story from ROP, and these cases should be documented and very well differentiated by ultrasonography. So the examiner skill is crucial in these cases to get a clear, good ultrasonic imaging. The 20 megahertz probe, we have the 10 megahertz and the 20 megahertz. 20 megahertz may be essential in these cases because it gives a higher magnification but a smaller field of view to the posterior pole mainly, and it can detect more easily if stage 1 ROP. The higher rate of detection, of course, of ultrasonography in stage 2, 3 and the advanced stage, but stage 1, if you are not so acquainted of the thickening in the posterior pole and the macular area, we can miss it easily. Of course, stage 2, we can find the shallow retinal detachment ridges, as we've seen in the previous slides, and stage 3, we can see the retinal thickening with a subtotal retinal detachment. So I can conclude that ultrasonography, it can detect all stages of ROP. ROP stage 1, we should be minded with it and look for it, because if we don't know the pathology and we are not looking for it, we'll miss it easily. It's the correlation between the clinical and the ultrasonographic data we can get in stage 2 and above is really can be correlated with the clinical appearance of the fundus with red cam or even fundus examination. And of course, it's very, very essential to have an ultrasonographic report on those cases because it's have the advantage of to examine the eye without any dilatation, with poor dilatation, and whenever is limited application of the red cam. Thank you very much, and it's a pleasure for me on behalf of the board of the Egyptian Society. This is our upcoming annual meeting in Egypt in April, and of course welcome everybody to attend. Thank you.